Lymphoid organs. There are 5 lymphoid organs in our body. And as I told you, you have to come from head to foot. First one is adenoids. Second one is tonsils. Third one is lymph nodes, because I take the cervical lymph node as an example, because lymph nodes are there throughout the body. Fourth one is thymus, and the fifth one is spleen. Okay, if you remember like this, from head to foot or from superficial to deep, we won't miss anything. How will you differentiate? When this lymphoid organ is lined by pseudostratified ciliated columnar type of epithelium, then it is adenoids. When it is lined by squamous epithelium with a lot of crypts, then it is tonsil, squamous epithelium. So the key you have to remember, for adenoids, it's a respiratory epithelium. For tonsil, it is squamous epithelium and the crypts. Lymph nodes, they always will have a capsule and the subcapsular sinus, and they are mainly divided into cortex and medulla. And you see the lymphoid follicles in the cortex, lymphoid follicles. We will see it in the pictures. Thymus, there is no capsule. They are arranged in a zigzag pattern. If you go to the high power, they are arranged in nests. And if you go to the high power, thymus is mainly divided into cortex and medulla. It's made up of, this is one lobule, and it is made up of cortex, which is outside, and then medulla. And in the medulla, you have the Husserl's corpuscles, nothing but epithelial pearls. They may look like squamous epithelial pearls. And one important thing in thymus, you should never see follicles in a normal thymus. If you see a follicle in thymus, it is an autoimmune disease, myasthenia gravis. Spleen will also again will have a capsule and extension from the capsule that are trabeculae. And here is one interesting point: the follicles are seen throughout the spleen. When you see one of the follicles in a high power, you will see one of arteriole in the periphery. But the name of the arteriole is a central arteriole. When you see a follicle with an arteriole in that, then it is from the spleen. And another interesting thing in spleen, these follicles are known as white pulp, and the area in between the follicles are known as red pulp. So the diseases of the spleen has to be divided into diseases of the white pulp and diseases of the red pulp. And if I tell you an example, you will understand better. Amyloidosis. Amyloidosis happens in the follicles. That's a white pulp disease. We call it Sago spleen. But when it happens in the sinusoids, we call it as Lordaceous spleen. So I hope you understand now the critical differences between the lymphoid organs. Now we will see the pictures.
Figure 9. Location and distribution of the lymphoid organs and lymphatic channels in the body. Internal content of the lymph node and spleen are illustrated in greater detail. First, we are seeing tonsils, cervical node, axillary nodes, thymus, thoracic duct, cisterns, colli, iliac nodes, bone marrow, lymphatic vessels, inguinal nodes, Peyer's patch, small intestine, spleen, white pulp, we are seeing white pulp, red pulp, a central artery spleen and vein, splenic sinusoids, arteries are seen, some trabeculae, and finally covered by capsule. And in a lymph node, we are seeing a cortex and medulla. In cortex, there are diffuse lymphatic tissues, cortical sinus, germinal center, and lymph node. And in medulla, we are seeing a medullary cord and medullary sinus.
Yes.
And surrounded by have a capsule, afferent lymphatic vessels, and efferent lymphatic vessels are present.
Yeah. So the afferent, when you see the lymph node more, you can see the capsule, and some of the lymphatics are coming and opening, which are all opening into the lymph node. They are known as afferent. Those which are leaving the lymph node are known as efferent, and you can see the valves there in the lymphatics. And beneath this capsule, you see the subcapsular sinus, which is marked in green. This is where the lymphatics will enter. And this is like a coffee filter. All the lymphatics coming through the afferent will drain into the subcapsular sinus, and from the subcapsular sinus they grow towards the, or they flow towards the hilum, and then from the hilum they will leave through the efferent. And you see the cortex, and nicely you can see the lymphatic follicles only in the cortex, not in the medulla. When you see lymphoid follicles in the medulla, then it is reactive lymphoid hyperplasia. Normally, you don't see follicles in the medulla, and when you see them, it is reactive follicular hyperplasia. And another important thing, to call it as metastasis for the tumor cells, they have to be present in the subcapsular sinus. Sometimes what happens, they may be in the afferent lymphatics. They will be sitting here, just outside the lymph node. So, if they sit outside, they are not lymph node involvement. They have to come inside the subcapsular sinus to call it as metastasis. So, when you see only tumor cells in the lymphatics outside the capsule or just at the capsule, you have to take deepers to make sure whether they are coming into the lymph node or not. If they are not in the lymph node, then they are called as lymphovascular invasion, even though they are sitting outside the lymph node.
Lymph node, panoramic view, stain hematoxylin and eosin, medium magnification. Pericapsular adipose tissue, capsule, subcapsular sinus, cortex, trabecular blood vessels, connective tissue trabeculae, afferent lymphatic vessels with valves, trabecular blood vessels, arteriole and venule, medulla, medullary sinuses, hilus, efferent lymphatic vessels, medullary cords, subcapsular sinus, lymphatic nodules, germinal centers of lymphatic nodules.
Yes. In the germinal centers, here you are all seeing the mantle zone, and this is the follicular center. This is one follicle. And you remember they are seen only in the cortex. This is the follicular center and this is the mantle zone. But sometimes you may see the follicles like this without any germinal center, and these are known as primary follicles. The follicles with the follicular center are known as secondary follicles. And why it is important? Primary follicle means they are not exposed to the antigen. They are all naive lymphocytes. They are not exposed to our immune challenges. Whereas in secondary follicles, they are exposed to the immune challenges. If you see tumor cells here, what will you do, ma? If you see tumor cells here, what will you do?
That is not invasive, sir.
So what will you do?
We have to take deepers.
Super, that you should not forget. In deepers, probably they may enter into the, they may from the afferent, they may enter into the subcapsular sinus. In that case, you have to call it as metastasis. But even in deepers, they are seen only in the blood vessel, then it will be, what will you call, ma? Even lymphovascular invasion. That's one point. Another point, what happens sometimes, the metastasis has happened in the lymph node. From here, they may extend outside the capsule. This is known as extracapsular extension. And this is another very, very important prognostic value, because they grouped the people, they looked into the prognosis of those patients who are positive in lymph node. Again, they can divide them into two groups. One are having a better prognosis, other one are having a worse prognosis. And then they looked into the cases of worse prognosis, and there they saw the extracapsular extension. Whenever you see lymph node mets, the second thing you have to look is there any extracapsular extension, because it carries a bad value or a bad prognosis. And you should be able to differentiate the extracapsular vascular invasion from extracapsular extension. Extracapsular extension means they open the shop in the lymph node and then they are spreading outside.
Lymph node showing capsule, cortex and medulla, sectional view, stain HND, medium magnification. From the left, there is connective tissue, afferent lymphatic vessel with valve, capsule, subcapsular or marginal sinus, connective tissue trabecula, trabecular cortical sinuses, germinal center of lymphatic nodule, paracortex or deep cortex, medullary cords, medullary sinuses, venule and arteriole, subcapsular or marginal sinus, lymphatic nodule, connective tissue trabecula, germinal center of lymphatic nodule, trabecular blood vessels, paracortex or deep cortex again, and then medullary sinuses and medullary cords again, sir.
In the medulla, you have the sinuses. Sinuses means they are like a river where all the drained blood will go through that. And they are surrounded by lymphocytes and plasma cells arranged in cords. So that's why in medulla there are two parts, medullary sinuses and medullary cords.
Figure 9.3, sir. Cortex and medulla of a lymph node. Stain Mallory as an 25 power magnification. Lymphatic nodule, germinal center, cortex, capsule, subcapsular or marginal sinus, lymphatic nodule, adipose cells, and then we see arteries, medulla, efferent lymphatic vessel with valves, medullary sinuses, and medullary cord.
Super.
Figure 9.4, lymph node, subcortical sinus, trabecular sinus, reticular cells, and lymphatic nodule, stain HNE, high magnification. We say subcapsular sinus, macrophage, capsule,
Yes.
trabecula, endothelial cell, and macrophage, small lymphocyte, reticular cells, germinal center, medium-sized lymphocytes. And again we see reticular cell, trabecular sinuses, endothelial cell, lymphatic nodule, peripheral zone, and lymphoblasts undergoing mitosis, macrophage, and lymphoblasts.
See, these are all the follicles, and the follicles are the one that are having B cells. And outside the follicles, there are some lighter areas, isn't it? And these are known as paracortical areas. Paracortical. And these paracortical areas are the T cells. And in the paracortical, you have blood vessels with endothelial cells that are, you remember the endothelial cells are usually flat. Here these are known as high endothelial cells. They may look like columnar cells or cuboidal cells, and these are known as high endothelial cells seen in the paracortex, and all the T lymphocytes will be around the high endothelial cells.
Then 9.7, thymus gland, panoramic view, stain, hematoxin and using. On low magnification, we are seeing a capsule, trabeculate, cortex, medulla, blood vessels, thymic, Hass's corpuscles also, adipose cells, and then we are seeing lobules of thymus and thymic, Hass's corpuscles, connective tissues of trabeculate, adipose cells, and in medulla, continuous between lobules, cortex, and finally we are seeing blood vessels.
Even though they put capsule, usually thymus won't have capsule. And see how they are arranged in lobules. These lobules are fixing each other. That's why they are known as ixapacels. And each lobule is divided into cortex and medulla. In the medulla, you have the Hass's corpuscles. Veda, can you see follicles in thymus?
No, sir.
If you see, what do you mean by that? No, you are correct. Normal thymus, no follicles. But when you see follicle, you have to think of autoimmune disease, myasthenia gravis.
Thymus gland, sectional view, stain, hematoxin and usage. On high magnification, we are seeing cortex with thymic lymphocytes, trabeculate, medulla, adipose cells, cortex with lymphocytes, blood vessels, epithelial reticular cells, thymic with Hass's corpuscles, degenerated center of thymic Hass's corpuscles, epithelial reticular cells.
Spleen, panoramic view, stain, hematoxylin and eosin, low magnification. Capsule, central artery, trabeculae, lymphatic nodule, white pulp, trabecular vein and artery, lymphatic nodule, white pulp, central artery, germinal center, central artery again, trabeculae, splenic cords in red pulp, venous sinuses in red pulp, pulp arteries. Spleen, red and white pulp, stain hematoxylin and eosin, medium magnification. Splenic cord, venous sinus, lymphatic nodule, central artery, germinal center, trabecular artery, trabecular vein, splenic cords, venous sinuses, pulp arteries.
Red and white pulp of the spleen, stain Mallory Azan, 21 times magnification. From the left, there is connective tissue capsule, white pulp, which has lymphatic nodule, germinal center, and a central artery. Uh, third is a connective tissue trabeculae, and fourth shows red pulp with venous sinuses and splenic cords. Next, we have palatine tonsil, stain HND under low magnification. From the left, there is stratified squamous non-keratinized epithelium, lymphatic nodules, tonsillar crypts, capsule, skeletal muscle. And once again, they have mentioned stratified squamous non-keratinized epithelium, germinal centers, trabecular with blood vessels, tonsillar crypts, and capsule.
Crypts are very, very important for tonsil. In a normal tonsil, in the crypts, you can see organism, which is very common in that area. Does anybody know?
Actinomyces.
Actinomyces.
Actinomyces, you see the splinter hippoli phenomena and actinomycosis. Adenoids, they have not mentioned. I don't know why they have not mentioned it, but you all please remember. Adenoids, lymphoid tissue with respiratory epithelium. Tonsils, lymphoid tissue with squamous epithelium showing crypts. Lymph node, capsule, subcapsular sinus, cortex that are showing follicle, medulla with medullary sinus and medullary cords. Thymus, lobulated structures, cortex and medulla, no lymphoid follicles, Husserl's corpuscles in the medulla. Spleen, capsule, trabeculae, red pulp, white pulp, and central arteriole in the white pulp. Let us start with the skin.
Overview figure 10 comparison between thin skin in arm and thick skin in palm, including contents of the connective tissue dermis. On the right side, it's divided into epidermis, then is dermis, next layer is the subcutaneous layer, then is adipose cells. In epidermis is further divided into stratum corneum, stratum basale, and the basement membrane. Sweat pores are present in the stratum corneum. Hair shafts are also passing through the stratum corneum. And dermis, eccrine sweat glands are seen. Apocrine sweat gland, vein, nerve, and artery is present. Then sebaceous glands are seen. Then erector pili muscle. Next is thick skin, which is again divided into epidermis, dermis, subcutaneous layer, then is the adipose cells, fat. Epidermis is divided into stratum corneum, basal, and basement membrane. Sweat pore glands are present. Sweat gland pores are present in the stratum corneum. Then in dermis, dermal papillae and epidermal ridges is seen. Eccrine sweat glands, vein, nerve, artery. Then Pacinian corpuscles. Then is the adipose cells.
Remember, I told you there are two venous, arteriovenous plexus, one here, one here. What is the importance of that mark?
It divides into papillary and deep dermis, the superficial plexus.
Very good. Then deep plexus, reticular dermis to subcutaneous tissue.
Figure 10.1, thin skin, epidermis and the contents of the dermis, stain Mason's trichrome, blue stain, low magnification. Epidermis, then the dermis divided into papillary layer and reticular layer and hypodermis.
Hypodermis, subcutaneous tissue.
Epidermis, there is stratum corneum and stratum spinosum. In papillary layer of dermis, we have dermal papillae. And then we have reticular layer of dermis showing ducts of sweat glands, erector pili muscles, sebaceous glands, sweat gland with ductal portion and secretory portion, hair follicle showing bulb and dermal papillae. And in the hypodermis, there is adipose tissue.
So here we have to have some concepts. The skin is divided into epidermis and dermis. Dermis is divided into papillary dermis and reticular dermis, and then subcutaneous tissue. What are the adnexal structures? Sweat glands, apocrine glands. Sweat glands are also known as eccrine glands. Eccrine glands, apocrine glands, and sebaceous glands. And we have the hair follicle. Why this is important? This is how the WHO divides the tumors of the skin. Tumors of the skin are classified into tumors arising from epidermis, tumors arising from the dermis. And in the tumors arising from dermis, it's mainly adnexal structures. Tumors of eccrine glands, tumors of apocrine glands, tumors of sebaceous glands, and tumors of the hair follicle. Now let us see how morphologically they will look. Sweat gland. Both the tubular and glandular structures will be like the same, but they are usually arranged in lobules. And these sweat glands, they will secrete, and the duct will go up, and then open into the epidermis. This is the connection of the sweat gland there, and they are lined by low cuboidal cells. Whenever there is a tumor with attempted duct formation, then we have to think of eccrine glands. Coming to apocrine glands, you see the apocrine metaplasia you might have seen. They are large cells with vesicular nuclei, and there will be lot of microvaculations in the cytoplasm. Abundant cytoplasm that can be eosinophilic in color or full of microvesicles, that is apocrine. Sebaceous gland, these are all the glands with the central nucleus with a lot of vacuolations in the cytoplasm. Again, it is abundant cytoplasm, clear cytoplasm with a lot of vacuolations, that is sebaceous gland. Sweat glands, cuboidal cells, apocrine glands, large cells with abundant eosinophilic cytoplasm. Sebaceous glands, centrally placed nucleus with a clear cytoplasm with vacuolations. These are all the three differences. Hair follicles, again, they will look like basal cells. Remember the basal cells here. So they will try to form the hair follicles. They will also have the peripheral palisading. Peripheral palisading is very, very important. And another important thing you have to remember, the pilosebaceous unit. The hair follicles and the sebaceous gland situated next to each other. Sebaceous glands are opening into the hair follicle. That is very, very important to remember. If the sebaceous glands open directly into the epidermis, then it is sebaceous hyperplasia. Normally, sebaceous gland should not open into the epidermis. Another thing you have to remember, see the muscle bundle coming up here. This is the erector pylori muscle. The sebaceous glands are situated in between the erector pylori muscle and the hair follicle. When you get goosebump, that means the erector pylori is contracting. When it is contracts, it will release some amount of sebaceous material also here. And another concept you have to remember, glands, depending upon the secretion, they are divided into eccrine, apocrine, and holocrine. In eccrine, the secretions happens into the lumen, no change in the morphology of the epithelium. Whereas in apocrine, the apical portions, for example, this is a apocrine gland. The apical portion get pinched off. That comes as secretions. Whereas in holocrine, the whole cell falls into the lumen. The examples, if you remember, then it is very easy. Eccrine glands or sweat glands. Apocrine glands or apocrine glands in the skin or in the breast, you can see apocrine metaplasia. Holocrine are the sebaceous glands. Subcutaneous adipose tissue is divided into lobules, and these lobules will have septa. So how will you classify the diseases of subcutaneous tissue? Those diseases that are having a lobular pattern involving the lobules, or that is number one, or diseases affecting the septa, or diseases affecting both lobules and septa. For example, paniculitis. It can be lobular paniculitis or septal paniculitis or mixed lobular and septal paniculitis.
The skin with epidermis, dermis, and hypodermis in the scalp, stain H&E, low magnification. From the left, there is stratum corneum, stratum spinosum, stratum basal with melanin, that is pigment granules, dermal papillae, arrector pili muscles, sweat glands with excretory ducts and the secretory portion, Pacinian corpuscles, subcutaneous layer with adipose tissue, skeletal muscle. On the right, there is arrector pili muscle again, sebaceous glands, reticular layer, hair follicles, internal root sheath, external root sheath, connective tissue sheath, hair bulb, and papillae, and they got blood vessels.
And remember, we saw in the epidermis, what are all the layers we saw on that day, Abhijit?
Yes, sir.
Stratum basal, dark blue cell. So this is stratum spinosum. Stratum spinosum forms the major portion of the epidermis. Above that, there are some cells with granular pigment. So then it is stratum granulosum. And above that is a very flat cells with keratin, then they are known as stratum corneum. There are 4 layers: stratum basal, stratum spinosum, stratum granulosum, and stratum corneum. They talked about melanocytes, and when you enlarge this area, the junction, you will see the basal cells, and in between the basal cells you see large cells with somewhat vacuolated cytoplasm. One thing you have to remember, even though we call them melanocytes and they produce melanin, the minute they produce melanin, they will export those melanin to the basal cells. The melanocytes won't have melanin, and the basal cells will have melanin pigment with interspersed large cells with vacuolated cytoplasm. So sometimes logic may not work. You may think melanocytes will have melanin. No logic there. Okay, melanin is exported, and this melanin is seen in the basal cells, and it is not seen in melanocyte. And the distribution of melanocyte depends upon the race of the people and site. For example, in the palm there is no melanocytes, whereas in the dorsum there is a lot of melanocytes. In white people there is less melanocytes, whereas in dark people there are more of melanocytes.
Hairy, thin skin of the scalp, hair follicles and surrounding structures, then hematoxylin and eosin, epidermis, stratum corneum, granulosum, and then stratum spinosum. Number 2 is sebaceous glands. 3 is hair follicles. 4 is dermis. Next, 5 is sebaceous glands. 6 is erector pili muscle.
Figure 10.4, hair follicle, bulb of the hair follicle, sweat gland, sebaceous gland, and erector pili muscle. Stain H&E, medium magnification. Duct of sebaceous gland, degenerating secretory cells, basal cells, sebaceous gland, nuclei of secretory cells. Erector pili muscle, connective tissue of dermis, excretory ducts of sweat gland, secretory cells of sweat gland, myoepithelial cells, cortex, cuticle, internal root sheath, external root sheath, connective tissue sheath, hair root, hair matrix, dermal papilla, melanin pigment, capillaries of dermal papilla comprising the hair bulb.
10.5, thick skin of the palm, superficial cell layers, and melanin pigment. Stain hematoxin and eosin. On medium magnification, we are seeing stratum corneum, followed by stratum lucidium, and then stratum granulosum with keratohyalin granules are present, and then stratum spinosum. Last is stratum basal with melanin pigments. Basement membrane followed by dermal papillae. On top, we are having desquamated cells, stratum corneum, excretory duct of sweat glands are open to it, and stratum granulosum, stratum spinosum, stratum basal with melanin pigment, mucinous corpuscle also, basement membrane, and capillary loops are present.
Super. And they have only one melanocyte. Can anybody identify the melanocyte? Can you see? No pigment, vacuolated cytoplasm. Whereas the basal cells are having heavily pigment.
Stain epidermis and superficial cell layers, stain hematoxin and eosin. We are seeing epidermis consists of stratum corneum, granulosum, spinosum, and basal layers, followed by dermis. On stratum corneum, we have excretory duct of sweat gland, basement membrane, dermal papilla, and melanin granules are present.
Thick skin, epidermis, dermis, and hypodermis of the palm, stain hematoxylin and eosin, 17 magnification. Adipose tissue, Pacinian corpuscles, sweat glands. Okay, hypodermis. Okay, this picture is showing hypodermis, dermis, and epidermis.
Correct.
In
Hmm.
Yes, sir. In epidermis, so we can see stratum corneum, stratum granulosum, stratum basale. In dermis, excretory ducts of sweat glands, and there's dermal papillae in the dermis.
It has to be in the dermis. See, the structures that are coming, these are the rete ridges, and in between the rete ridges is the papillary dermis. All the adnexal structures are quite deep in the dermis and they extend into the subcutaneous tissue. In some diseases, it may come off, for example, scleroderma.
Apocrine sweat gland, secretory and excretory portions of the sweat gland. Stain hematoxylin and eosin, medium magnification. Excretory portion of a sweat gland, myoepithelial cells around secretory portion, secretory portion of an apocrine sweat gland, adipose cells of hypodermis, connective tissue of dermis, secretory portion of an eccrine sweat gland, hair follicle, blood vessels.
Apocrine portion. They will get pinched out and they come as secretion. These are apocrine glands. And you can see the difference between eccrine and apocrine very nicely. These are more eccrine. This is more apocrine.
Cross-section and three-dimensional appearance of an eccrine sweat gland. Stain H&D low magnification. On the left, excretory duct in epidermis, excretory duct in dermis, secretory cells, two labelings, and then myoepithelial cells, excretory duct in epidermis, excretory duct in dermis, and secretory portion, sir.
See, if you are lucky, you will get this whole thing.
Yes,
Because it's very difficult to get them all in one plane when you are cutting.
10.10 glomus in the dermis of thick skin. Stain hematoxylin and eosin, high magnification. Number 1 is nerves with axons. 2 is glomus. 3 is ducts of the sweat gland. 4 is dermis. 5 is the arteriovenous junction. 6 is epithelioid cells of the glomus. 7th is connective tissue sheath around the glomus. And 8th is venules.
The glomus are nothing but the periendothelial cells. Okay, they are situated around the blood vessels, and they are regulators of temperature and pressure. That you have to keep it in mind. And why it is important? Because these cells may develop into tumor and they will become glomus tumor. One of the painful tumors of the skin. Remember bangles. BANGLES. B is blue rubber blub nevus. A is angiolipoma. N is neuroma traumatic. G is glomus tumor. L is leiomyoma. ES is eccrine spiradenoma. This is the mnemonic for painful tumors of the skin.